This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. Hi, I'm Dr. Deepak Megur, and most beginner surgeons struggle while performing sculpting in their first few cases. When they're sculpting, the sculpting is uncontrolled. The trenches are irregular, broad, and non-linear. In this video, I'm going to highlight one golden tip which is going to make their learning curve of the 4-quadrant technique much more easier, and that will ensure that the trenches are regular, smooth, and predictable. Now this is a pearly white cataract. We can see those radial spokes of solan cortex, and although the cataract looks white now, I'm not sure about the underlying cataract density. So I prefer to do these surgeries under block with an ocular massage that would reduce the pressure in the eye and make the eye softer, and that gives us a better control to do a rhexis. The capsule is stained and the chamber is refilled with OVD. I create a 2.8 mm posterior limbal based incision. Time to perform the rhexis. I puncture the capsule with the forceps, and this is the Dr. Haldipurkar forceps which I'm using. And so as I begin my rhexis, I'm a little bit cautious. I'm just trying to assess whether the tear is under control or not. And since the tear is under control, I'm proceeding to do a single stage rhexis, and I'm conscious not to attempt for a bigger rhexis simply because there could be a chance of the rhexis running away in that process. Now a surprise awaits me as I clear the superficial cortex. I can see the cataract is quite dense and brown, and I thought this is a good case to demonstrate a 4-quadrant technique. So I've been teaching many residents and trainees phacoemulsification, and now I'm fairly convinced that most beginners find it very difficult to do the sculpting with both the hands inside the antechamber. When they're doing, the control that one should have while making the sculpt is not there. So for the beginners, I'm changed my protocol of training, and now I'm suggesting that they should start trenching with both the hands. This is what I'm doing. The phaco handpiece is held with my right hand. The left hand is supporting it, and by just using this one hand, we're able to create a trench. Now, of course, the nucleus pushing has to be avoided. This is possible if we use the appropriate amount of energy necessary for that density of the cataract. Now this is a fairly dense cataract. I'm using 90% continuous torsional mode, and the flow rate is kept at around 16, the vacuum is 100. So predominant functionality of the phaco machine in this stage of the surgery is cutting. We want an uninhibited cutting, and we don't want any attractability or holdability. So we dial down the flow rate in the vacuum to as low as possible. You can see by just using one hand as well, we can go ahead and do the sculpting quite efficiently and effectively. Now, if you can recall, in my previous videos, I would always emphasize that stabilize the nucleus with the left hand so that you get used to the fact that when dealing with a very mobile nucleus, the left hand would help us in preventing the nucleus from moving around. For absolute beginners who are just starting out, I think the single-handed trenching is a very good idea. By having a better control in the movement of the phaco tip, what it results is we get a long, linear, well-designed trench. Otherwise, usually when the beginners do, we get very wide trenches, irregular, and that can be minimized. So this is something which I want to convince. Even for rotation of the nucleus, as we can see, just using the phaco tip to rotate the nucleus. So this was a mature cataract. We don't have a very dense epinuclear sheet, the cortex, but still in this dense nucleus as well, we could manage to sculpt the nucleus quite easily in a very controlled manner. I'm just trying to assess the depth of the trench. I think I'm able to see the color change. The brown part has minimized now, and I can see slightly darker areas beneath at the floor of the trench. So until that level is reached in the adjacent grooves as well, the trenching is continued. Eventually, I'm happy with the depth of these trenches, and now is the time to perform the lateral separation. Long sense yoke is used as a second instrument, and then the two instruments are placed on the floor of the trench, and then the lateral separation maneuver is done. Now, because the trench was adequately deep, very minimal force is required to separate these quadrants from each other. This is very important. When you're doing lateral separation, again, be mindful that your second instrument is not tugging or stretching the rexus margin, because we are always at risk of tearing the rexus during this aggressive maneuvers to do the lateral separation. So be mindful of all these potential issues which may arise. So now we've got 4 big fragments which need to be consumed, and the quadrant removal mode is on. And now I'm going to use torsional energy but with high flow rate and vacuum, so that the emulsified quadrants are easily and quickly consumed. While doing this, I usually prefer to use my second instrument as a shield on top of the tip, so that the fragments are prevented from jumping around and hitting the endothelium. It's very important that we fill in OVD timely, especially in such situations where we're dealing with the dense cataract. So eventually the last piece of the nucleus is emulsified. Very little amount of cortex is there, which is aspirated. Time to implant the lens. The chamber is filled with OVD, and a single piece hydrophobic lens is gently maneuvered into the bag. The OVD in front and behind the IOL is being irrigated out. The wounds are hydrated, that's it, the case is done. Just a quick revision here. For beginners, I would recommend that when you try to sculpt, use both hands to do the trenching part. This would help the novice surgeon to get linear, straight trenches which are narrow and not irregular and wide. This would help to understand, to develop the control of the movement of the phaco tip in the eye. And we have found that this is quite easy to replicate by the beginner surgeons. So that will thank you for watching, and hope you found this helpful.